Thank you, everyone. Thank you for inviting us. So we'd like to present a very interesting and unfortunate case of a 45-year-old gentleman. Do you want to go to the next slide? So the overview will be, we'll do a case presentation of the initial part of the patient's clinical course. It'll be followed by a discussion of the question of reinfection versus persistent infection in this patient's case. Then we'll go on to the next part of the patient's clinical course, followed by discussion of the systemic dissemination rise of the SARS-CoV-2 variants that we observed. And then at the end, we'll discuss some of the immunological findings of that we observed with this specific patient. So the patient we'll discuss is a 45-year-old gentleman who was diagnosed with the autoimmune condition antiphospholipid syndrome in 1998. So a very long-standing disease. However, he was diagnosed with catastrophic APS, which is a more severe variant. And his APS was characterized by both venous and pulmonary thromboses, adrenal hemorrhage, coronary vasculitis, aortitis. And approximately 5 months prior to his admission, he was diagnosed with diffuse alveolar hemorrhage, which is a very severe and life-threatening complication of catastrophic APS, where basically blood accumulates in the alveolar spaces. That prompted an augmentation of his already significant immunosuppression. On the right-hand side is a summary of the numerous anti-inflammatory therapies that he received over the course of his illness. And they included rituximab, which is an anti-CD20 monoclonal antibody that leads to B-cell depletion. He was always on some dose of corticosteroids, never lower than 20 milligrams of prednisone, but he was on as high a dose as 1,250 milligrams of methylprednisolone, and that is indicated in the black lines in the graph. He also was started on eculizumab, which inhibits the cleavage of C5 by the C5 convertase. That was started as a treatment for his catastrophic APS and when he developed DAH. He was also on cyclophosphamide. That's indicated in the pink bars at the top of the graph. And cyclophosphamide is it binds DNA and it can cause apoptosis. It inhibits and it has effects on both humoral and cellular immunity, but its greatest effect is on the T cell population. And then lastly, he was on ruxolitinib, which is a JAK1, JAK2 inhibitor. So once again, a very sort of complicated immunosuppressant course for a disease that was mostly refractory to therapy and very progressive, although he did have episodes of clearly responding to therapy. Next slide. So he was initially diagnosed with COVID-19, which we call day 0 for the remainder of the talk, after he presented with nausea, abdominal pain, and persistent fevers. He actually, at that point, denied any respiratory symptoms or any change in his baseline exertional dyspnea. And he was actually discharged on room air from his initial admission after receiving a 5-day course of remdesivir. Between day 6 and day 68 of his initial diagnosis, he actually had 3 admissions with a variety of complaints, mostly abdominal pain. He had 1 admission for fatigue and dyspnea, but he was very, he lived by himself and actually quarantined at home and reported no sick contacts during this time period. We met him when he was readmitted on day 69. He also was admitted at that point with abdominal pain, but even though that was his primary complaint, he was found to have a new oxygen requirement. And if you look on the right-hand slide, there are representative axial images of his chest. So day -38, this is a period of quiescence. His diffuse alveolar hemorrhage had responded to therapy at this point. But as you can see on the lower right-hand side, the lung, which is typically black, there are still areas of ground glass opacities that had not fully resolved, even on maximal therapy at that point, but his DAH was considered controlled. Day -1 was the day prior to his initial diagnosis with COVID-19. And there you note the interval development of worsening ground glass opacities compared to his prior baseline. And as I mentioned earlier, we met him during his hospitalization on day 69. And in that case, the areas were similar in involvement, but there was a more organized appearance, although there was still extensive ground glass opacities at that point. Next slide. So we were sort of in a conundrum because even today, the SARS-CoV-2 PCRs are reported a binary way, either negative or positive. And at that point, which was the dark ages of our understanding of COVID, it wasn't clear if he was still viral shedding or could he possibly still have persistent disease. At that point in the literature, there were no reports of anyone having persistent infection or even viral shedding, 70 plus days out from their initial infection and diagnosis. So we actually requested that the cycle thresholds be reported for his numerous PCRs that he had had over the course of his illness. And for the uninitiated, the cycle threshold is the cycle number in RT-PCR reaction where the fluorescence threshold crosses the background. And the threshold cycle, the number, is actually inversely proportional to the relative expression of the gene target. So the lower your cycle threshold, the much higher number of, the much higher amount of the gene target is in the sample. So if you look at the left-hand side, that's actually the actual CT values for all of his nasopharyngeal swab RT-PCRs. And in the graph, you'll see that when he actually had 2 negative cycle thresholds before he was initially diagnosed with a positive on day 0, his cycle threshold continued to decline, nadir'd, or I should say peaked at day 18. And then as expected, actually, his cycle thresholds began to increase, consistent with control of viral replication. And he had, before he was readmitted on day 69, he had a high cycle threshold of 37.8. However, when he was readmitted, his cycle thresholds were found to be 26 and 27. And that almost 12-fold increase in cycle thresholds actually corresponded to approximately a 4-log increase in viral titer. So we were quite concerned at that point that he could either have recrudescence or possibly could he have potentially been reinfected either in a nosocomial way or during his, in the community, as he had had multiple admissions prior to that time. So I'll pass it. And the questions we had for our infectious disease colleagues and Dr. Lee will address is, whether the nasopharyngeal swabs and the cycle thresholds were reflective of increased viral load or persistent viral shedding. Did the patient have recrudescence or reinfection? And then clinically, whether his oxygen requirements were actually due to worsening diffuse alveolar hemorrhage, or was he suffering complications of COVID-19?
Thank you, Manuela. So again, just to introduce myself, I'm in the Division of Infectious Disease, and I also run a virology laboratory at the Brigham Women's Hospital. And so we were brought in to help the primary team try to figure out a number of these questions, including, do these CT values actually truly reflect increases in viral load? Just because there is some difficulty in interpreting and directly kind of interpreting CT values into absolute viral load. So in our laboratory, we do have a viral load, a quantitative viral load assay. And when we measured the samples over the course of those 5 months, we were able to confirm that these CT values indeed represented dramatically elevated levels of SARS-CoV-2 viral load within not only the nasopharyngeal swabs, but also other compartments as well. The nasopharyngeal swabs are shown here in the red lines. And you can see that 5 months after the initial diagnosis of COVID-19, this individual's SARS-CoV-2 viral load in the nasopharyngeal swab was right around 9 logs, or about 1 billion copies per ml nasopharyngeal swab fluid. And this still remains one of the highest viral loads that we have measured in our lab to date. In addition, we were able to detect SARS-CoV-2 within the sputum, but also somewhat surprisingly, in the blue line, you can see that we were able to find SARS-CoV-2 viral RNA within the plasma as well. And some of the key questions that these results brought up for us is, is this persistent COVID, or is this a reinfection with a new strain? Now, again, going back, this is to summer of 2020. There had yet been any prior descriptions or reports of either reinfection or persistent infection at that time. In addition, most of the data up to that time have also shown that the virus is no longer infectious, or about a week after the initial infection. And the question was, is this virus, especially the ones that were present 5 months after the initial infection, is it's actually infectious virus? Are there signs of directed viral evolution and viral escape? And also, what do we make of this plasma viremia, right? Is this plasma viremia solely confined to individuals who are immunosuppressed, or can we find it in a broader population of individuals? And is it predictive of any worse outcomes? So first, we were able to provide some of these samples to Amy Barzak and her postdoc Julie Bacow at the Reagan Institute BL3 facility, where they have a viral culture assay using Vero E6 cells. And on the top left here, you can see a negative control where it's maybe a little bit hard to see, but it actually is a monolayer of cells. On the top right are positive control, and you can see that that monolayer has been disrupted by cytopathic effects from the replicating virus. And when we provided samples from 2 different days, day 75 and day 143, you can see that there was evidence of infectious virus at both of those days. Next, we performed viral sequencing, but before I show you the viral sequencing results, I wanted to put SARS-CoV-2 viral diversity in perspective for all of you, okay? So this is what's known as a phylogenetic tree. And this is a phylogenetic tree of HIV envelope sequences that we downloaded in 2020 from around the globe. The longer the branches, the more diverse the viral population is. This is the phylogenetic tree for HIV envelope in the provirus, in the DNA, for one individual. This is the phylogenetic tree for H1N1, the hemagglutinin, also sequences from 2020. And here is SARS-CoV-2. See that little schnitzel right there that you can't even really see unless you have a 10x magnification. So what this really shows is that SARS-CoV-2 viral diversity really pales to what is known in terms of commonly thought of viruses like HIV and even influenza. And this is largely due to the proofreading ability of the RNA polymerase that increases the fidelity of the viral RNA replication. So as I show you phylogenetic trees during the rest of the presentation, I just want everyone to kind of put it into perspective when compared to other commonly studied viruses. So we were able to obtain samples from across the 5 months of infection and performed whole viral sequencing. This is done by a couple very talented members of my lab, Manish Chowdhury and James Reagan. And here, you'll see that on the right, you'll see the time points where we were able to obtain the samples for sequencing. This is a circular phylogenetic tree. And the arrow and in the kind of the dark red, you'll see the phylogenetic analysis of the sequences that we were able to obtain. These are all whole viral sequences. And what this study shows very clearly is that all of these sequences all come from a common ancestor, and that this is really phylogenetic evidence of viral persistence and evolution rather than a viral reinfection. Now, at this point, you might be wondering, well, what about those cases of reinfection that we've been hearing about in the news, and how do we distinguish between viral persistence that I'm telling you we're seeing here versus reinfection? Well, oftentimes, it can be straightforward to tell the difference on a phylogenetic tree. On the right is our case, and on the left is an example of one of the first reinfection cases that was published. This was a 25-year-old man from Nevada who had 2 episodes of COVID last spring and summer. The phylogenetic analysis here, which are kind of highlighted in this area and right over here, and also in the branches that are orange colored right here, and also kind of on the bottom left over here. It really shows that in contrast to our sequences, the 2 sequences from this individual did not group together, and instead were on the opposite sides of the tree. So we've now shown that this appears to be a case of persistent infection, and that the virus is infectious even 5 months later. So I wanted to kind of turn our attention now to the other question that we had, which is the plasma viremia that was seen in this patient. How common is it within the general population, not just immunosuppressed individuals? And is there any implications with the detection of plasma viremia? Now, to answer these questions, I actually want to briefly show results from a couple different cohort studies that we performed before we kind of go back to the rest of this case. So the first thing that we did was look at a group of hospitalized patients collected through the MASS CPR, the Massachusetts Consortium for Pathogen Readiness, and this is in collaboration with Shu Yu and Bruce Walker. And we looked at SARS-CoV-2 viral load across a range of sample types in individuals who are hospitalized with SARS-CoV-2. These are all adults. And what you can see is that the highest viral loads were seen in the sputum samples, but interestingly, more than a quarter of all hospitalized patients had detectable SARS-CoV-2 plasma viremia. And in the past few months, we've also started a collaboration with Mike Philbin, Marcia Goldberg, and Nir Cohen to study in a cohort of emergency department patients from MGH. They have collected plasma samples from over 300 patients who presented to the MGH ED. These are all adults who had COVID-19 and acute respiratory dysfunction or distress, as shown here under the inclusion criteria. And you can see that on the bottom, there's a wide range of acuity levels from those who had very severe disease, including needing to be intubated or died, to those who really were admitted with relatively little oxygen support or were discharged from the ED. Now, their ability to obtain an IRB of approved waiver of informed consent here really allowed for an unbiased sample collection of everyone who came to the ED who met these criteria. And overall, first, what we found was that SARS-CoV-2 viremia could be found in 35% of ED patients with respiratory distress. That SARS-CoV-2 viral load was associated with increased systemic inflammation and lower lymphocyte count. This is a heat map showing a correlation between SARS-CoV-2 viral load in the first column here with all of these other factors. And you can see that there's a direct correlation with factors like CRP and D-dimer and LDH, as well as elevated creatinine and LFTs, so renal and liver dysfunction, and inversely correlated with lymphocyte count, which is also known to be a marker of potentially more severe disease as well. In addition, a baseline plasma viral load at the time of the emergency department presentation was predictive of maximal COVID disease severity during the course of the entire hospitalization. And here we're stratifying individuals into 3 different groups. And this is all viral load data that was done by Ijia Li, an ID fellow in my group. These individuals were categorized by either viremia above 2 logs, viremia but below that level, or who are aviremic. And you can see that in the highest viral load strata, about 1/3 of all the participants eventually died, and versus about 13% in the intermediate viral load strata and 8% in those who did not have detectable viremia. And then similarly, on Kaplan-Meier analysis, you'll see that mortality curves also separated by levels of plasma viremia, with individuals with the highest viremia, which is in red, having the greatest risk of death and then those who are aviremic having the lowest risk of death. And then finally, higher plasma viral load was associated with key pathways for interferon response and organ damage. And these pathways can be grouped into a number of different specific areas. Not surprisingly here, high viral load is associated with elevated levels across a broad range of proteins associated with interferon and monocytic response. And this is all performed by the O-link analysis. And also high plasma viral load is also associated with evidence of tissue damage, including cardiac proteins, endothelium, and vascular enriched markers and coagulation pathway proteins. So really a lot of this data supports that plasma viremia may play an important role in viral pathogenesis, potentially from systemic dissemination. And I'll go into that in a little bit more later in the talk as well. So just to give a summary of some of this first part of the virology analysis, we saw evidence of persistent COVID-19 in this immunosuppressed patient, that high levels of infectious virus was present even 5 months after the initial COVID-19 diagnosis. And that high plasma viral load within the general population is associated with systemic inflammation, induction of key proteins and interferon response pathway, cardiovascular dysfunction, endothelial damage, and predicts mortality as well. So I'm going to turn it back to Dr. Cernadas for the next part of the presentation.
Thank you. So the next part will discuss the sort of second phase of his illness. So after he had been discharged from that admission on day 91, he actually stayed out of the hospital until day 105. He was discharged on 4 liters of supplemental oxygen at that time, and was able to get off oxygen at rest, although continued to need it with exercise. But he was readmitted with cellulitis, but rapidly developed an increased oxygen requirement during that admission. There was significant concern that he had had a recrudescence of his DAH, despite his persistent SARS-CoV-2 PCRs. He was treated with higher doses of corticosteroids, IVIG, cyclophosphamide, ruxolitinib, and was eventually also treated with both a third and a fourth dose of remdesivir. And due to progressive worsening on day 145, he actually received the Regeneron antibody cocktail, which is a combination of 2 antibodies against the SARS-CoV-2 viral spike protein. And that was at that time by compassionate use. Unfortunately, his respiratory status continued to decline, and he was subsequently intubated and placed on mechanical ventilation. While he was intubated, he did undergo bronchoalveolar lavage on day 150, and he had a BAL that was sent and had a SARS-CoV-2 RT-PCR cycle threshold of 15.8. In addition, he had a positive culture for Aspergillus fumigatus, and had already, because of increased serologic markers for fungus, had been started on antifungal therapy. Unfortunately, due to progression of his respiratory decline and hemodynamic instability, he ended up passing on day 154, days after his initial diagnosis. He did have an autopsy, and tissue samples were obtained at that time for RNA extraction. Just going to briefly go over the pathology that was, and these slides were provided by Dr. Bobby Padera of the pathology department at the Brigham. And the gross picture, which is the first picture that you see on your left, you see the lung is pretty hepatocized looking. It's very red, beefy red, consistent with the diagnosis of diffuse alveolar hemorrhage. That there's a white arrow pointing to sort of a yellow area with a cavity. That's an area with cavitary Aspergillus pneumonia. There are other foci, yellow foci of disseminated Aspergillus on the gross as well. On the picture to the immediate right, this is an H&E of the lung. And you see these islands of red islands. Those are areas of diffuse alveolar hemorrhage. The arrows point to hemosiderin latent macrophages that are distributed through both the lung as well as these areas of DAH. And then on the bottom, there's a lymph node which is hard to recognize as a lymph node because it's profoundly depleted of lymphoid cells. And there actually are no germinal centers whatsoever in this lymph node. I did want to mention that there have been some case reports of DAH in patients with COVID-19 without underlying diseases such as APS. But interestingly, they've all been in immunocompromised hosts. So I'll pass it back to Dr. Lee.
All right, thank you. So we were able to obtain some tissue samples from Dr. Padera from the autopsy, and in conjunction with Dr. Doug Kwan from the Reagan Institute, we were able to obtain some viral RNA samples from across multiple tissue types to measure levels of SARS-CoV-2 viral load. And what we found was that, first of all, not surprisingly, the highest viral load could be found in the respiratory tract, including the main stem bronchus and peripheral blood. But I think it's interesting to note that you can actually detect viral load across the entire body with high levels within the spleen, but also detectable levels in the heart, the liver, the small intestine, and the colon as well. Now, if you take into account the size and volume of the organ, you can start to get a sense of what is the whole total body burden of SARS-CoV-2 infection. And here again, the lungs make up the primary area of SARS-CoV-2 infection, about 82%, but a substantial subset of all of the viral RNA can be found in other organs within the body as well, and with the largest in the spleen and also in the liver. And so I think all of this data, again, provides evidence that systemic dissemination of SARS-CoV-2 could be playing a role in viral pathogenesis. So now I wanted to move on and talk a little bit about the rise of the SARS-CoV-2 variants. And this includes the B.1.1.7 variant that was originally found in the United Kingdom, the B.1.351 variant from South Africa, the P.1 variant from Brazil. And there has been, I think, a lot of sensationalism in the media, but there really are reasons to also be concerned about some of these variants as well. Now, if you look at some of this phylogenetic tree where I've plotted out the B.1.1.7 and the B.1.351, you'll notice that some of these variants, especially the B.1.1.7, appeared quite suddenly and without kind of intermediate branches that would show some evolutionary intermediates. And the sudden appearance of variants like B.1.1.7, where you've got a large collection of mutations and deletions appearing at the same time, suggests to me that there is some evolutionary jump, right, from a hidden source of viral evolution in the community. Well, where could this hidden source of viral evolution be coming from? Well, I see two different possibilities. First is that we're missing viral evolution that is happening around us because we're not doing enough sequencing, so that we're not picking up these variants until there's been widespread dissemination in the community. Now, until about a month or a month and a half ago, if you look here at the United States and the rate of viral sequencing, you'll see that we weren't even in the top 40 countries in the world in terms of viral sequencing based on the number of infections. But the CDC at this point, I think, is recognizing the importance of this, and we have been doing better. You also notice here that Britain is in the top 10, and I don't think it's necessarily a coincidence that this strain B.1.1.7 was found in England, and really that's where a lot of the alarm from these new variants have really arisen, was from England. Because they've got one of the most robust viral sequencing operations out there. And we're just not going to find these variants if we don't look for them. So on the other hand, I think that there is another potential source for the emergence of some of these variants, and that is with individuals with persistent infection. And now also, in addition to B.1.1.7 and B.1.351, I've also plotted out here on the phylogenetic tree the sequences from a number of additional published persistent COVID cases. And you can see that there indeed is quite a bit of viral evolution, intra-host viral evolution within these individuals. And you can imagine that at the, towards the end of some of these kind of viral evolutionary pathways, if it then jumped into the community, that it would appear to be the emergence of a brand new strain with that looks maybe something similar to B117. Now, I will say now at this point, the caveat that this has not been proven, and that there is, first of all, no evidence that our patient had infected anyone else. He was very good about isolating and lived alone, but that it is a possibility that this may have happened, that could have happened in order to be another source of potential viral variants. So I also wanted to actually take a moment here and show you the actual sequences that arose in this individual, because I think it can actually be quite illustrative. So this individual, the sequences here are shown, first of all, the mutations compared to the initial sequence is shown at the top here across the entire SARS-CoV-2 genome. Red represents synonymous mutations, and blue represents non-synonymous mutations that actually have an amino acid change, and black lines represent deletions. So the first thing to notice is that there's a lot more blue than there is red, and that suggests that there is evidence of directed viral evolution, that much of these changes actually are non-synonymous changes that affect the amino acid. In addition, you can see that the changes in this genome is more focal and not evenly distributed across the entire genome. And in particular, you can see that most of the mutations are actually found in the spike protein, which of course, as you all know, represents the outer shell and the knobs on the outer shell of the virus. The spike protein, or spike gene, I guess S gene, makes up about 13% of the viral genome, but it actually represented almost half of all of the amino acid changes that were found in this individual. And within the spike gene, much of the mutation was found in the receptor binding domain, or the RBD, where it made up about 2% of the viral genome, but more than a third of all the mutations found in this individual. And in addition, I want you to point out two specific mutations that during the course of this illness, this individual developed a 484K mutation, as well as a 501Y mutation here. These are now considered the key drivers of viral escape against neutralizing antibodies. That's the 484K, and including the B117 variant and or including the South African variant and the Brazilian strains. And then 501Y is thought to increase viral replication as well. So you can see really in this remarkable case that viral evolution happening in front of our eyes, that in retrospect, these mutations that were emerging in this individuals really became hallmark mutations that were found in some of these new variants that are arising from around the world. And then when we looked at the rates of viral evolution across multiple published cases of persistent infection, we found that the rate of viral evolution was fairly accelerated in those with persistent COVID-19. But that, well, in addition, many of these individuals with persistent COVID were treated with either convalescent plasma or monoclonal antibodies, but it appeared to slow the rate of viral evolution over time on the right-hand side here, but did not halt viral evolution. Now, I think we're used to seeing the complete shutdown of viral replication and evolution in our HIV patients who are treated with modern antiretroviral therapy. But this shows that the viral suppression by convalescent plasma or monoclonal antibodies is not absolute, like ART. I also want to just to emphasize again that this individual we did receive the Regeneron monoclonal antibody about 5 months after the initial infection. And you can see that after receiving the Regeneron antibody, that the viral load did decline over the subsequent few days. So we wanted to look at whether there was evidence of potential Regeneron resistance mutation emergence. And we partnered with Jesse Bloom, who's at the University of Washington. Jesse's been mapping the constellation of potential monoclonal antibody escape variants using an East display assay, and has identified a range of mutations for the Regeneron antibodies. And so when we put in and looked at our deep sequencing data for this individual, we showed that despite the initial drop in viral load after Regeneron treatment, there was a rapid rise in mutations shown here in blue that together conferred resistance to both of the monoclonal antibody treatments. And that while it's been hoped that the use of combination monoclonal antibodies could prevent or delay the emergence of resistance, this case shows that resistance can still occur. And so the summary of this second part of the virology data is that an autopsy study did show disseminated SARS-CoV-2 RNA across multiple anatomic sites, that there is evidence of accelerated viral evolution and escape, including viral evolution and escape against convalescent plasma and monoclonal antibody therapy, and that persistent infection could represent one source of novel SARS-CoV-2 variants. So I'm gonna throw it back here to Dr. Manuela.
Hi, so the next section is going to focus on some of the immunologic analysis of this patient. And to start off with, going to present some of the data that was performed in Zhu Yu's lab with her done by her postdoc Shoshan Kuo. So this is before I point out this data about the specific patient on the left-hand side, I did want to sort of provide a framework, because we did not have healthy controls in the analysis we published, but there have been several very elegant studies published that have looked at the immunobiology of SARS-CoV-2 and COVID-19. So in this box to the right, this is taken from a Nature Medicine paper from Catherine Blish's group in Stanford. And I just focused on both the plasmacytoid DCs and B cells. So these are figures of the proportion of plasmacytoid DCs and B cells in peripheral blood samples that were taken from either healthy controls in blue, moderate cases of COVID-19 in yellow, and severe cases of COVID-19 in red. And as you can see, SARS-CoV-2 and COVID-19 actually result in a decline in peripheral blood plasmacytoid dendritic cells and B cells. And plasmacytoid dendritic cells are this link to the adaptive immune system, and they are critical in viral immunity, and they typically produce very high amounts of type 1 interferons. So it is interesting that just infection alone can cause a reduction in plasmacytoid DCs. And as you see with the B cell on the right, there was a significant reduction of peripheral B cells as well. So getting to our patient, which is the data on the left, the first, the top graph on the left is a display of the major immune cell types in the peripheral blood of this patient at day 81. And the patient is in red. The age-matched hospitalized patients with active COVID-19 are in gray. And what's striking is, how that he has almost no peripheral B cells. He clearly has some peripheral B cells, but they were markedly reduced, even compared to patients with active COVID-19 who almost uniformly have some degree of lymphopenia. His myeloid DCs were similar, but as in the Dr. Blish's publication, there's a significant decrease in plasmacytoid DCs, almost undetectable in this patient population, with overall similar levels of monocytes, NK cells, and CD4 and CD8 T cells. In the next graph over is a representation of the total percent B cells and the antibody secreting, or ABSCRT, compared to non-antibody secreting. And as you see, about 60% of the patients' B cells are antibody secreting, which is significantly different from his age-matched controls with COVID-19. And this is probably due to the fact that he received rituximab approximately 3 months prior to this analysis, which can have long-lasting effects on your B cell population. And since they typically delete the non-antibody secreting, it's actually consistent with his Rituxan exposure. And on the next two figures, is further sort of stratifying the types of B cells that he had, both looking at antibody secreting cells where he had similar or typical numbers of plasma cells and plasmablasts, and then looking at the non-antibody secreting cells where he clearly had more naive as well as double negatives compared to his peers. On the bottom row of graphs is an analysis of both of his T cells and monocytes. And although there weren't significant dramatic differences, he did have low numbers of CD38 high, CD4 positive T cells. He also had, which is in the first figure. In the third figure over, looking at differentiation, he had low numbers of peripheral T follicular helper cells. And in the lymph node, they're very critical in augmenting and stimulating B cell responses. In the periphery, they play a similar, although less complex role. So it is interesting, given the fact that he had such profound, B cell dysfunction, that he also had low levels of T follicular helper cells in the periphery. And then he also was noted to have lower numbers of circulating monocytes. Next slide. And then the Gaurav Geha from the Ragon and Michael Seaman from the Beth Israel helped do even more sophisticated analyses of this patient's SARS-CoV-2, but these SARS-CoV-2 specific immune responses. So these are day 81 peripheral cells from this patient, and his ability to mount SARS-CoV-2 specific T cell responses were analyzed by CFSC proliferation in response to positive control, which was CMV, as well as a selection of SARS-CoV-2 peptide pools. So on the top series of plots are the CD4 cells, and on the bottom are the CD8 cells. And the proliferation is indicated in those boxes with the percentage. So there was very little background proliferation as noted in the control. He did have a response to the CMV pool as noted in the next set of plots. He also had, as expected, not a significant response to the non-structural protein pool, SARS-CoV-2 non-structural protein pool. However, he had a pretty robust response to the SARS-CoV-2 spike pool. And then in the last set of graphs, both the CD4s and CD8s did respond to a combination of nucleocapsid, membrane, envelope, and open reading frame 3A pool. So despite his significant immunosuppression, he was actually able to mount robust T cell responses. On the right, these are Dr. Seaman in his lab performed SARS-CoV-2 specific neutralization antibody assay. So this was an assay looking to see whether or not the patient's the antibodies the patient had in his own peripheral blood, whether they would be able to neutralize and kill virus. So this was a pseudovirus assay with wild type SARS-CoV-2. And the percent neutralization is indicated on the y-axis, and the serum dilution is indicated on the x-axis. The red dots represent a positive pool serum. And as you can see, the dotted line indicates the neutralization of the 50% neutralization. And although this patient did have neutralizing antibodies, they were several logs lower at all the days that were studied. So on the different colors represent different days that the serum of serum from different days of the patient's infection, from day 0 being the first day he was found to have a positive PCR. So in summary, the immunophenotyping demonstrated the patient had very low B cells, a marked reduction in plasmacytoid DCs, and a reduced T follicular helper cells, as well as classical monocyte levels compared to age-matched patients with COVID-19. He was, and the data also suggests that his T cell proliferation assay demonstrated robust CD4 and CD8 T cell responses to the spike and other structural protein antigens, as well as his inability to significantly augment antibody responses over the course of his illnesses and multiple viral recurrences. And the future questions, that I think this case raises are: which immune defects predispose to persistent SARS-CoV-2 infection and severe COVID-19? Which immune therapies and immune defects promote viral evolution? And which immunomodulatory therapies may improve outcomes in patients with both COVID-19 and persistent COVID-19? And before I conclude, I just wanted to, I forgot to mention her name, but Dr. Bina Choi, one of our excellent pulmonary critical care fellows, was an integral part of this case, and it's in the publication. Thank you.
So that was fantastic. There are a number of questions. I will start to go through them. Dr. Randolph asked, so is the virus that is detected in the blood and tissues viral particles or actual live virus that can grow? And then the second part of the question is, was the patient positive for virus in the blood when the PCR from the upper respiratory system was negative?
So first question, is the virus in the blood and in the tissues replication competent? That is challenging. We were able to culture virus from the upper respiratory tract, mainly because if you look at all of these viral culture assays, they generally have a limit of detection of somewhere around 10 to the 6, 10 to the 5th, 10 to the 6 viral copies per ml, below which the virus is unable to be cultured. Is that because that viruses below 10 to the 5th, 10 to the 6 are replication defective, or is it because that's the limit of detection for the assay? And I think that is an open question. And actually, we've had some experience with HIV, in the sense that when we try to culture virus from plasma from individuals with less than, say, 10,000 copies, even though we know these individuals are infectious, right, and they're able to transmit, we have real hard time culturing this virus because just the limited detection of these assays. So I don't know. That's the short answer of whether or not the plasma and the virus from the other parts of the body are infectious. I would suspect yes, but it's very challenging to answer that question per se. But when we sequence the virus, how about this? Actually, probably the best way to say is that when we did whole viral sequencing, the virus from the plasma, I did not see any obvious defects. So it was what I would consider a genome intact virus. And when we have sequenced other plasma samples from other individuals as well, we also found that there's no evidence of defects from those viruses. So I would say it is a whole virus rather than just a fraction of a virus or a viral RNA fragment. And then
the second part was, and this is actually relevant. I have a patient who I'm very curious about this, and I might ask a follow-up question myself based on your answer, but was the patient positive for virus in the blood when the PCR from the upper respiratory system was negative?
In this patient, generally the plasma viremia really tracked pretty closely with the upper respiratory tract. So really every time you saw kind of an increase in the nasopharyngeal viral load, you also saw an increase in the plasma viral load. We've also looked at other mass CPR participants, and we find that to be fairly consistent as well when it comes to upper respiratory tract, that generally those who are hospitalized, the highest nasopharyngeal swab viral loads and the highest plasma viral loads are early during the course of hospitalization, right when they get admitted, right? And then they kind of start trending downwards generally over time. But interestingly enough, if you look at the lower respiratory tract, actually viral load appears to peak potentially a few days or even a week after that. So you'll see that kind of, there are patients in the hospital at the Brigham where you'll have a negative nasopharyngeal swab viral load, but yet the lower respiratory tract viral load can be quite high.
It's interesting. I have a patient with X-linked gamma globulinemia who was asymptomatic just on COVID screening around Christmas, and then 1 month later started developing respiratory distress and has CT findings of multifocal pneumonia, but now with negative nasopharyngeal swabs. So unfortunately, he's an adult and he's in an outside hospital, and I'm kind of trying to track things along, but it sounds like they should be looking at bronchoscopy to figure out if they can find any viral signal there.
Absolutely, there's no doubt in my mind that you have to look down in the lower respiratory tract and sample down there. Actually, if you remember one of my first slides looking at where the viral load was highest amongst the different compartments, it was sputum that was the highest in hospitalized patients. And many more of those individuals are positive versus nasopharyngeal swab, just because individuals who are hospitalized who are more severe lower tract disease, that's where all the action is. And that's where the replication is. So that's what I completely agree with you, that they need to be looking down in the lungs to make sure that this person, to diagnose COVID or disease.
Another comment from Dr. Randolph about a patient at Boston Children's who was positive for almost 6 months, then had bone marrow transplant for AML and was still persistently positive, and they sequenced her virus serially and found that deletions came and went. So the question is, have you seen variants come and disappear with treatment?
I have to say, SARS-CoV-2 has surprised me in how dynamic the viral population can change. And you can see that with the sequences that I showed over time, that the E44K came and then it kind of went again. And then if you look at the deep sequencing data from the post-Regeneron monoclonal antibody, that there was actually some rapid increases in some of these resistance or escape variants or mutations, and then those kind of decrease, I think, shortly thereafterwards. So it's a lot more dynamic, the shifts in viral population, compared to what I'm used to for HIV, where you develop drug resistance for something and then you can find it for several months at least before it might kind of wane over time. But here, the resistance mutations don't really sweep to fixation as easily, unless I think there is some huge benefit in terms of viral replication that you're seeing with maybe the 501Ys and such. So I'm not surprised, especially if some of these are resistance mutations to certain antibody escape, or whether it's some drug, where if the drug levels wane, then you'll see population shifts where those mutations specific to that antibody or that drug that you're giving is also will wane over time. So.
Thank you. And then it looks like Dr. Grand posted a question directly to Dr. Cernadas, so perhaps she could read the question and answer it. Did you get the?
Sure. Let me just pull it up. Sorry.
Or Dr. Grand could just ask the question, I suppose, as well.
Sure. Can immunocompetent people who have been immunized acquire a variant and become infected?
Yeah, probably would defer to Dr. Lee. I mean, I think the jury's still out on this, although I think the vaccines appear to be pretty effective against the current variants that we have. Although that clearly may not be the case forever, but I would love to get John's impression as the virologist.
Yeah, when people talk about variants, they tend to lump them into one category, but actually variants are not all the same. If you look at the B.1.1.7 variant from the UK, which is the one that's really sweeping through the US now, it actually has very little effect on vaccine efficacy. Whereas other variants, like the ones from South Africa, the B.1.351 and the P1 variant from Brazil, those contain mutations like E44K that appears to have much more of a detrimental effect on the vaccine efficacy. And if you look at the outcomes from some of the vaccine trials that have looked at its effect on some of these variants, for example, the Johnson & Johnson vaccine, right, where the vaccine efficacy was 72% in the US, but only 57% in South Africa. And a lot of that is thought to be due to the fact that it's less efficacious, a little bit less efficacious against some of these new variants. So it is a source of concern, but I don't want to leave on a low note. I want to say that, to emphasize that these vaccines are highly efficacious. They're phenomenal. And that even against some of these new variants, they can prevent severe disease. And that we should still be encouraging everyone to get them and not to be too afraid of these new variants yet. But and that the more we can get folks vaccinated, I think the less likely that these variants can even emerge in the first place. So I really think that's a key step here.
Perhaps on that note, just one more question. Dr. Nader noted that certain populations, particularly those treated with rituximab, particularly for vasculitis and lupus, seem to have more severe COVID-19 disease, and if we should be prioritizing certain populations based on this for vaccination to prevent kind of variant super spreader events.
Well, Manuela, do you want to start?
Well, I think that, for a lot of the cases we've seen, they don't even mount an immune response. So I think that, if you have the ability to defer or delay exposure to Rituxan before immunization, but I think in a lot of the cases that we're seeing in the hospital with patients who have gotten Rituxan, they don't appear to mount a response to the actual virus itself, which makes you worry about their ability to respond to immunization. But I'll let Dr. Lee chime in.
Yeah, so we have done a systematic review of all these cases of persistent infection, and it does appear that one of the hallmarks of persistent infection is B cell immunosuppression. Now, this individual that we had discussed actually had suppression of multiple different arms of the immune system, right? B cells, T cells, and steroids and such. But it does appear that to me that rituximab is a potential key driver, and that B cell immunosuppression is a risk factor for persistent infection. And I think that it is not unreasonable to focus, make sure that these individuals are followed a lot closer, because first of all, the CDC criteria for when people might leave isolation is really all based off of immunocompetent individuals, and we I think we need to really pay a lot closer attention to our immunosuppressed patients, and that I think it's not unreasonable to be a little bit more upfront and a little bit more aggressive about treatments as well for these individuals who may need some help to augment their own immune responses.
I think we're probably out of time for questions, but I'm sure that Dr. Lee and Dr. Cernadas would be willing to take maybe email questions afterwards if anyone has burning questions. So thank you so much for this really enlightening talk. I really enjoyed it, and it sounds like the audience did too.
Thanks for having us.
Thank you.